Good morning, everybody. Thanks for joining us. We're assuming and expecting most people will be joining us online today, as always. You'll notice that we are in LK 120 on campus as well. So we're excited to be restarting the in-person medical grand rounds and always keeping the online Zoom component in perpetuity. We'll always have that, but it's nice to see some people in person as well. we got people screaming because it's a packed house in here. You can hear all the screams. We'll just start in just a minute. We want to just make sure everybody gets a chance to join who's joining online, and then we'll introduce our speakers in a moment. Again, we're really excited for today's Grand Round speakers. We particularly look for really special topics and speakers, and we definitely found a couple for today. So we're excited to have our main presenters. I'm going to turn it over to Dr. Irene Sonu. Thank you so much for being with us today and also helping host our whole session this morning. So here, I'll turn it over to you.
Thanks, Daryl. Good morning, everyone. It is a real distinct pleasure to be able to introduce two colleagues of mine who will be giving today's medicine grand rounds. Dr. Meredith Craven is a licensed clinical health psychologist with a master's in public health. She received her PhD from Northwestern Feinberg School of Medicine and her MPH from Emory-Rollins School of Public Health. As a psychogastroenterologist and the director of GI health psychology in the Division of Gastroenterology and Hepatology, she provides evidence-based brain-gut behavior therapies to patients with digestive disorders. Her goal is to work collaboratively with patients and their other GI providers to help improve GI symptoms, quality of life, and well-being. She is passionate about integrating mindfulness, culturally valued practices, and patient strength into her work, focusing on inclusive and individualized care. Dr. Linda Nguyen is a clinical professor in the Division of Gastroenterology and Hepatology. She received her MD at UCLA and completed residency and fellowship at California Pacific Medical Center. Dr. Nguyen joined the GI division at Stanford in 2008 and has become a thought leader in motility and in particular gastroparesis. Beyond her accomplished academic career in motility, she also has devoted her time towards addressing physician burnout, diversity and inclusion in academia, and mentorship. On a personal note, she has been my mentor and friend for almost a decade, and I am deeply indebted to her. With that, I will have Drs. Craven and Nguyen take it from here. Thanks. Okay, can you hear me now? Okay. So our goal today is to discuss very much at a high level how you can integrate psychogastroenterology or GI psychology into our GI practice. And I'm going to focus here on disorders of gut-brain interaction, but this really helps in all of chronic GI conditions. And I'm happy mostly to introduce Meredith Craven here, whom I've spent the last 3 years trying to recruit here, and probably one of the highlights of my time here. So these are our disclosures, and nothing we're going to talk about here involves these disclosures, except for the fact that a lot of the therapies we're going to talk about in neuromodulation are off-label for functional GI disorders or DGBIs. So I'm going to start by just level setting because most people don't think about DGBIs or disorders of gut-brain interaction. Historically, it was known as functional GI disorders, but the challenge is that when you think of functional, you think of like it's in your head or quote functional, and you know it carries stigma and a negative connotation. The DGBIs span a wide spectrum of disorders from the esophagus all the way down to the anal rectum. The ones that you recognize the most are probably irritable bowel syndrome, constipation, functional dyspepsia, functional diarrhea. So why is this important?
This is a survey done by the Rome Foundation looking at the worldwide prevalence of these functional GI disorders, or DGBIs. And they sent out an internet survey. The top graph here are the internet surveys, and the bottom image here are the prevalences where they went door to door and interviewed households. And what's astounding is that over 40% of individuals surveyed had one of the symptoms, or met criteria for one of those DGBIs. 40%. So of the 200 plus of you out there, 40% of you have some symptoms that meet these criteria. And when you look at the most common DGBIs, functional constipation was the most common, followed by functional dyspepsia, and then irritable bowel syndrome, functional diarrhea, and bloating. Just to take a second on IBS, the prevalence you see here is about 5%. And if you read kind of the older literature, where we often quote the prevalence of IBS being, 10 to 15% of the population, or at some points, up to 20% of the population, when the Rome Foundation changed the categorization of irritable bowel syndrome in Rome 4, it made the criteria stricter so there was greater specificity but lower sensitivity. So the prevalence decreased by about 50% there. Can't have a talk these days without mentioning COVID at all. This is a study done actually from a group at Stanford here, led by John Gubaton and Leland Satan, where they looked at patients who underwent COVID testing and prior diagnosis of DGBI here at Stanford, and looked at their healthcare utilization and symptoms in the 6 months before COVID and the 6 months after COVID. And you can see here that in the 6 months after COVID, there were more symptoms of abdominal pain, nausea, vomiting, diarrhea, constipation, greater healthcare utilization, inpatient hospitalizations, endoscopies, imaging, outpatient. Now, this is a database study, so looking at our EMR, and in the first 6 months of the pandemic, really the testing was done in patients who were either in the ER, getting admitted, having procedures. So there may be a selection bias here, but the reality of it is that if you look at outpatient clinics, we don't test people in the outpatient, and we definitely saw an increase in the outpatients of healthcare utilization. And planning for the future, over 80 million individuals have been infected with COVID-19 in the last 2 years. And we are expecting a surge of post-infectious irritable bowel. And you've heard many times people who are much smarter than me in terms of talking about the ACE2 receptors. There are ACE2 receptors in the gut, and there are GI manifestations of COVID-19. We all know that. Majority will recover, but some will go on to develop a post-infectious functional GI disorder, or potentially irritable bowel syndrome. And this is a proposed mechanism of that, which I won't go into any detail. And we have historical precedents on viral infections leading to post-infectious IBS. And these are studies in adults and in pediatrics. So in the pediatric study by Miguel Sops here, that 16% of kids who had a rotavirus infection went on to develop IBS, and in adults, over 20%. So if you are conservative in your estimates of 80 million and 16%, we're talking about 12 million new cases of IBS we'll be seeing. I definitely can't handle 12 million new patients. So we're going to need everybody out here to be aware of IBS and help manage patients. So if I'm asking you to help with IBS, I have to tell you what is IBS and how do you diagnose this. So what is irritable bowel syndrome, or IBS? So this is based on the Rome 4 criteria. It's recurrent abdominal pain that's associated with a change in bowel habits with 2 or more of the following. It's related to defecation. There's a change in the form or frequency of the stool. And on your right there, you'll see the Bristol stool form. And if you haven't been introduced to the different quality and pictures and types of stool, this is your introduction here. So type 1 is the hard lumpy stools, and then you have type 7, which is the watery stools. Normal is three to 4. So someone may tell you that they have 10 bowel movements a day, but their stool is Bristol type 1. They are not having diarrhea. That's more on the constipation side. Now, this is where we get into the challenges here with irritable bowel syndrome. Based on the Rome 4 criteria, you have to have symptoms for 6 months. Imagine having these symptoms for 6 months without a diagnosis. And the reason why the Rome Foundation used the 6-month cutoff was to increase the specificity for clinical trials. So the Rome criteria were developed specifically for clinical trials, not for clinical care. So this past year, they published a commentary proposing that they change the criteria to more than 8 weeks to allow for more rapid diagnosis and treatment, as opposed to having patients wondering and physicians wondering, like, well, what could be going on for the next 6 months. And for those of you who don't know, April is IBS Awareness Month. IBS, again, is irritable bowel syndrome. It is not inflammatory bowel syndrome. It is not irritable bowel disease. If you're going to write about it, tweet about it, please use the right terms. So, what are DGBIs? To go back to think about the normal control of the gut. And again, I'm not going to go into the weeds of this, but these 2 diagrams are to show you the complexity of digestion and motility, control of sensation. So for those of you eating breakfast, drinking your coffee, beyond deciding what you're going to eat or drink, lifting that up to your lips, chewing and swallowing, after the swallowing, you're done. Your body takes over, and everything else is on automatic control. And this control, and the rest of it is controlled by the enteric nervous system, which is intrinsic to the gut, and then the autonomic nervous system, which is in the sympathetic and parasympathetic nervous system. And then if you dive down even deeper, you see here that there's the microbiome, the epithelium with the nerves there, and then the endocannabinoid system, neurotransmitters, the hypothalamic pituitary axis. So when you see these complex diagrams, what it means is that there's a lot of areas where things can be perturbed. So any perturbation of this normal control can lead to alterations in motility and sensation of the gut. So that taking a step back, what does this homeostasis look like? So normally the brain and the gut are connected. You have normal mood, cognition, motility, sensation, everything's fine. If you have a disruption, either because of diet, antibiotics, infection, it can lead to changes in the mucosal immunity, microbiome, motility, sensation, leading to these symptoms, and then which can affect the mood, cognition, and then you get into this vicious cycle. It can also start centrally with stress, lack of sleep, and I don't have data to show you here, but there are studies that show that disordered sleep can lead to disruption in the brain-gut connection. And again, just kind of simplistically thinking about the autonomic nervous system, there's 2 branches. There's the sympathetic and parasympathetic, and the sympathetic is your your parasympathetic is your rest and digest, and your sympathetic is your fight or flight. And what I tell people is that it's kind of like when you're being chased by a bear, your sympathetic nervous system revs up, correctly so that you can run away from the bear. But if your sympathetic nervous system is revved up and you're sitting there, drinking your coffee or eating breakfast, that's abnormal. And what can happen when your sympathetic nervous system is revved up is it can increase CRF, cortisol, mast cell activation, release of neurotransmitters, inflammatory cytokines, changes in the microbiome. When you have a decrease in the parasympathetic nervous system, it can cause increased gut permeability, secretions, heightened sensation, altered motility. So all this together can lead to this disruption of homeostasis. And so this is kind of developed this biopsychosocial model of the functional GI disorders. So we see the clinical presentations and the outcomes, but if you take a step back There are the early, there's the genetics and environment. So early adverse childhood events, genetics, social culture, all these things play a role in the final clinical presentation and outcomes. And these early factors can actually affect the psychological factors as well as the brain function connectivity. And this is in part why we see so many overlapping conditions with functional GI disorders. So patients with DGBIs, in addition to their GI symptoms, often suffer from other comorbidities, including depression, anxiety, but also these extra intestinal functional GI or functional disorders or overlapping pain conditions, which is chronic pelvic pain, interstitial cystitis, chronic fatigue syndrome, fibromyalgia, migraines, mitral valve prolapse, dysmenorrhea. So you can see here that patients with functional GI disorders are more likely to also deal with extra GI chronic symptoms. And what this shows you here, the red are the ones with comorbidities, blue is without. In terms of quality of life overall in all factors, poor quality of life in those with functional GI disorders and these comorbidities, and then also worsening of the symptom severity. So when you think about treating patients with functional GI disorders or irritable bowel syndrome as an example, there's kind of this pyramid. Majority of our patients have mild symptoms, and the main thing that you can do, the best thing you can do for patients is make a diagnosis, validate their symptoms, stop saying it's just IBS. It's not just IBS. It is IBS, and it's affecting the quality of their lives. It may not be life-threatening, but it is life-altering. So make a diagnosis, validate the symptoms, explain the pathophysiology, why they're feeling their symptoms. And as the symptoms become more severe, you may need to bring in help. Thus, we have Dr. Craven here in terms of a multidisciplinary approach. And this is the role of using neuromodulators. So we've talked a lot about nerves and just kind of globally thinking about how neuromodulators work. There's the antidepressant effects, the visceral analgesia, and there are changes into the motility of the gut. And there are peripherally acting neuromodulators, which we use specifically in the gut. And then there's the more centrally acting ones. And mostly what I'll say here is that get comfortable using neuromodulators. No matter what specialty you're in, you will encounter or take care of patients with chronic pain. Beyond validating them, have tools. Don't refer everybody out. Start by learning how to use one neuromodulator, and then once you get comfortable, add another. And the general concept is you have your first line therapy. And in the world of DGBIs, we typically use TCAs and SNRIs. So you start there. And then if it's not effective or they're partially effective or there's limited by side effects, you augment. And these are the therapies that we typically augment with. The delta ligands are the ones I most commonly use. And then you have the psychological therapies like cognitive behavioral therapy and hypnosis with Meredith we'll talk about. And then I'll finish with this last slide to introduce Meredith, and that we talked about kind of the psychopharmacology in terms of the different pharmacologic things that we can use to help treat our patients. But then there are the behavioral interventions, and why are those important? When you think about kind of how we interact with our environments, there's sort of the behavioral inhibition system, and then there's the activation system. Most individuals default to this inhibition or this punishment system where if there's pain, you think of it as danger and you anticipate punishment. And so then you withdraw and avoid doing the activity. So for example, in IBS, the withdrawal is you stop eating or you start limiting foods or you don't leave your home. And the behavioral activation symptom is more the positive, which is more goal directive. It's more beneficial. And so with the punishment system, it actually increases the pain perception and the hypersensitivity, hypervigilance. And a lot of this starts with, the maladaptive thoughts. And we'll now introduce Meredith, who'll talk about how she works with individuals to then, alter these maladaptive thoughts.
Dr. Nguyen. Right, so jumping off of that wonderful introduction, I want to talk a bit about the cognitive, affective, and behavioral processes that we know can influence. In particular, I want to highlight hypervigilance, anxiety. These are two overlapping processes that we know can drive and maintain bothersome symptoms. A patient is experiencing hypervigilance. As soon as they wake up, they're scanning their body. Okay. Hello. Okay, great. Okay. So for visceral hypervigilance, this is the patient who, as soon as they wake up, they're scanning their body looking for alarm symptoms. This is also the person who can experience and really will describe food moving throughout their gastrointestinal system. So I can literally feel the food moving down my esophagus, entering my stomach. And we know this can drive that GI symptom-specific anxiety. So this is the patient who is very much worried about their symptoms. As soon as they experience some type of stomach disturbance, they're immediately catastrophizing. They're worried this could mean something bad is going to happen. It's also the person who is practicing a lot of avoidance. They're, as Dr. Nguyen mentioned, maybe not leaving the house or severely restricting their food because of fear of the consequences. I do want to note that this is different from generalized anxiety, which is more of that day-to-day worry, and impending sense of doom, whereas these are very much focused on GI symptoms. In terms of brain-gut behavioral therapies, we have several evidence-based and empirically supported therapies, and as the name indicates, these are focused on that brain-gut connection and GI symptoms. So in brain-gut behavioral therapies, cognitive behavioral therapy, also known as CBT, and gut-directed hypnotherapy are the two that are most used and that also have the most research to support. I really like this chart on the right or this figure, because I think it really highlights how we're able to individualize care based off of the patient's presentation and the processes that are driving symptoms and symptom experience. And when we're using brain-gut behavioral therapies, we're really helping dampening down those uncomfortable GI sensations and increasing a patient's coping and resilience. As I mentioned, there's scientific support, with the most being for CBT and gut-directed hypnotherapy. And as you can see, we have support for a wide variety of digestive disorders, including disorders of brain-gut interaction, as well as those organic conditions like inflammatory bowel disease. This is just to further demonstrate the efficacy of our treatments. When working with a patient, I always like to begin with this model to really demonstrate that anybody, but particularly patients with DGBIs, can get stuck in a gut symptom cycle, where we can see this connection between an initial GI sensation, the thoughts, behaviors, and bodily responses that can increase GI symptoms and worsen the experience of them. And I also like to show this to empower patients and demonstrate there are several areas that we can target to help you get unstuck from this cycle. And in particular, we're going to be targeting the thoughts, behaviors, and sympathetic arousal. So let's dive into a bit into CBT. I'm sure many of y'all have heard of this. CBT was originally developed as a treatment, as a psychological treatment for depression in the 1970s. and has gone on to demonstrate efficacy in a wide range of mental and physical health conditions. The foundation to CBT is that there's a connection between our thoughts, emotions, behaviors, and in health psychology context, we bring in body sensations as well. And when using CBT, this is a collaborative therapy in which we're helping patients in the present moment focus on drivers of symptom experience. And essentially, we help patients learn what you think and what you do affects the way that you feel. And previously, Dr. Nguyen presented the Biopsychosocial Model. CBT is a great fit for that model. So let's go through a case example. We'll call this patient Jane. Jane is a 25-year-old woman who has mixed IBS. And we can see these drivers of symptom experience that I was talking about earlier, those cognitive, affective, and behavioral processes. So for her, she's constantly worried that she might have an accident. So she's forcing herself to have a bowel movement before car rides or important social events. During our time together, if I'm using a CBT approach, I'm going to begin with a bit of psychoeducation. So this is information about CBT, the rationale and efficacy of CBT and IBS. I'll give information about the brain-gut connection, the role of stress in particular of driving GI symptoms, as well as just further information that could be helpful for her particular case. For relaxation training, we're really targeting that autonomic arousal and trying to increase coping skills. So all my patients, I teach diaphragmatic breathing. It's a great tool. I was using it before giving this talk to calm myself down. And then we'll also teach things like progressive muscle relaxation or body scan. And this is also another way where patients are able to get in contact with their body. So we're helping them learn you don't have to be so fearful of your body and these GI symptoms. In terms of cognitive restructuring, we're really targeting those maladaptive automatic thoughts. So we have a situation and a patient instantly has that automatic unhelpful thought, I'm going to have an accident. We want them to have a more balanced approach to their thinking and to their GI symptoms. So for Jane, that worry about having an accident, we can start poking holes in that. So what's the evidence for and what's the evidence against? Possibility versus probability. Sure, there is a very low possibility that you could have an accident, but in all probability, it's not very likely. So is it really worth it to avoid that important social event or to restrict your eating so much? We're also going to target flexible coping. So when a lot of patients arrive, they're really great at problem solving focused coping, but not so good at emotion focused coping. So we really want to have that balance. There's going to be certain situations where we can't take a next step, where we don't have a lot of control. So we have to rely on emotion focused coping. And then finally, exposure techniques. The idea behind this is when we face our fears, we learn that we can handle them. We learn that maybe they're not as bad as we were predicting. And we can do multiple types of exposure, including interoceptive. So that physical sensation, maybe that looks like tightening your belt. So you can experience that sensation of tightness and learn, okay, after 15 minutes, it's actually not that bad. I'm feeling okay. And as you can see, what's great about these brain-gut behavioral therapies are that they're short term. So on average, I'm seeing patients for around 6 sessions. Some patients need more, some patients need less. And in CBT for IBS, the number needed to treat is 3, and we have long-lasting results with up to 4 years. I think that's how long the research has been in terms of longitudinal research. So what we're doing is we're giving patients skills that they can use to apply not just to their GI symptoms, but also to other stressors in their life. In terms of gut-directed hypnotherapy, this is a form of medical hypnosis. So medical hypnotherapy has been around for a really long time. In the 19th century, it was used during surgery for anesthesia. So we can see its application in many different areas with benefit. So in hypnosis, I'm bringing a patient into a relaxed yet focused state. So they're at a heightened state of relaxation and a heightened state of mental receptivity, where they're more receptive to therapeutic images and suggestions. And for gut-directed hypnotherapy, we're targeting those cognitive affective processes that we know drive symptoms, as well as physiological processes like central nervous system pain. We'll call this patient Mitch. So this is a gut-directed hypnotherapy case example. So Mitch is a 50-year-old male who's been experiencing globus sensation. He has a really stressful job. He's raising teens who are at home during COVID. So he's pretty stressed out and hasn't been coping very well. And he's feeling his emotions a lot through his throat and this globus sensation. In terms of intervention, the gut-directed hypnotherapy intervention, similar to CBT, it's important to begin with psychoeducation. We really want the patient to buy into this treatment so that they'll show up and engage and do homework between sessions. So again, I'm providing treatment or education around the rationale and efficacy of gut-directed hypnotherapy, and again, information about the role of stress and that brain-gut connection. When the patient comes in for GDH, the sessions can be between 20 to 45 minutes, and I'm using different imagery. So first, the patient's getting into a very relaxed state, and then for globus, an example, some of the imagery that I might use is having the patient imagine an ice cube in their throat. So we know that when an ice cube is in touch with something warm, it's going to melt. And so you can imagine that ice cube melting and that feeling, that free feeling in your throat expanding. So now your esophagus feels free of sensation, a bothersome sensation. In the days and weeks forward, you will pay less and less attention. In between sessions, patients are listening to these recordings 5 out of 7 days of the week. And then they will come for a booster session in about 3 months. A lot of patients like that, just to have one more gut-directed hypnosis. And then they have that skill and that they can actually practice self-hypnosis and know how to calm their autonomic nervous system and just have a different relationship with their symptoms. And the brain is doing a better job of turning the volume down on so similar to CBT, this is an efficacious treatment with number needed to treat of 4. It's long lasting. Patients seem to really enjoy it, and they just have another tool in their toolbox so that they're no longer practicing a lot of avoidance, which we know can really restrict a person's quality of life and exacerbate symptoms, and allow them to, really engage in meaningful activities while at the same time having tools if and when their symptoms do flare. So just to wrap things up in terms of the rationale for integrating GI health psychology, there are many reasons. First, we know medical care alone is not enough. Many patients continue to experience these bothersome symptoms despite, first-line medical care. The brain-gut axis. We've learned so much in recent years about how powerful the connection between the brain-gut and microbiome is, and how stress and other variables can interfere with that communication. And finally, as I really touched on throughout my talk, is the role of these cognitive, affective, and behavioral factors or processes that we know drive symptom and symptom. With that, I will hand it back to Dr. Nguyen.
Okay, so Meredith, I love the NNTs for our cardiologists out there, because those NNTs are, much better than our MINT cardiology trials that they can celebrate. But I wanted to end with this slide here for our value-based colleagues out there. Song, I'm looking at you, even though you're not here live. So you're thinking, okay, Linda, Meredith, sounds great, sounds expensive. how do we incorporate this multidisciplinary care in a cost-effective way? And my argument here, and this is a study out of Australia, and you have to kind of, change the Australian dollar to the US dollar, but, conversion rate aside, what they did here was they randomized to groups of patients with functional GI disorders. So they took the whole gamut of patients who came in, and they were randomized to either standard care, where they were seen by a gastroenterologist like we do in our clinic, versus a multidisciplinary clinic. And the way it worked was, in the standard care, patients were seen by the gastroenterologist, and that individual could still refer patients out to a dietitian, a behavioral psychologist, or a psychiatrist, but those individuals were outside of their clinic. In the multidisciplinary clinic, all the patients were again seen by the gastroenterologist, who would refer patients to individuals within the clinic. So the GI dietitian, psychiatrist, biofeedback therapist, the hypnotist, they were all within the clinic. And so they were seen in the same space. But in addition to that, even if they weren't seen, they had weekly case conferences where they talked about the patients. And then they looked at what happened with their symptoms, as well as healthcare utilization. And a priori, they kind of looked at these global improvement in symptoms. And it was a 5-point Likert scale, where it was, slightly better, or, markedly better, versus same, slightly worse, markedly worse. And they wanted to look at the patients who marked that they were better. And in the multidisciplinary care group, 84% said that they were better. And then, if you think about the much better, the Likert of 5, half the patients felt like they had marked improvement in their symptoms. And when you look at all of their symptom scores, and I didn't look at it, provide this here on the table, but when they looked at quality of life, multidisciplinary group always fared better. When you look at the individual hospital costs, and this is looking at, physician visits, blood tests, x-rays, imaging, endoscopy, the standard care was cheaper, but not by lot. You're talking about $24.21 versus $24.85. But then when they looked at the average cost per primary outcome, meaning those who met the intention to treat analysis outcome of improvement, that the multidisciplinary care group was cheaper. So on a per patient basis, the standard care is cheaper. But when you look at from a system standpoint and cost effectiveness for the outcomes, because then these individuals who are better can return to their life. And so you're looking at indirect costs, that then it is more cost effective for the whole global system to have a multidisciplinary approach. So we're fortunate to have a team now of GI dietitians. So these are dietitians who are versed in our GI disorders, not diabetes, trying to do GI disorders, but GI specific dietitians. We now have Meredith for our GI psychology. We have a team of great gastroenterologists, and we work with our social worker. And so, slowly but surely, we've amassed a multidisciplinary team. And I can't say that I'm more proud of this team that we've put together. And so thank you, and we'll take any questions.
Thank you so much for a wonderful talk. I'm going to field some questions that are in the Q&A here. So the first one is, I'm struck by the commonality of your catastrophizing progression slide with migraine patients. Is there a relationship between migraine and DGBI?
Yeah, so I showed a slide earlier about the extra GI manifestations. And so, more and more we're talking about these overlapping pain conditions. So patients with migraines are more likely to have DGBIs and vice versa. In patients with, DGBIs, if you ask them about migraines, they are more likely to have migraines. There's something in terms of the overlapping pain conditions, there's probably a commonality that, is still yet to be determined, that is at the peripheral level, at the receptor level, as well as the central processing. But yes, it's very, very common.
What is the role in exercise in IBS?
Yeah, so there's some really great evidence that exercise can be a really good, important behavioral intervention. And in particular, there's been research on yoga. So that is a recommendation that I often give patients, because a wide range of patients can participate in that.
Did you mention the male-female rate of incidence? I'm assuming of DGBI.
Yeah, it's definitely more female predominant than male.
So there's a couple of people that have asked similar questions about this. So there's a high demand for CBT among patients with IBS and other DGBI, but it's difficult to access therapists. Are there any plans for increasing capacity for treating these patients?
Yes. Yes. So I think the first step was my hiring. So I was very excited to become part of the team. So that's one way that we're improving access. And hopefully eventually, as the research indicates, this is a cost-effective treatment that patients really enjoy. So hopefully, eventually more psychologists can be hired. But in the meantime, what I would recommend is going online and Googling Rome Foundation GI Psych Directory. And this is an online directory where you can type in your zip code and see if there's a provider near you. And there are also apps that patients like, but I would encourage you to use that in coordination with your healthcare team.
Yeah, just to add to that, we're not going to be able to train enough psychologists or social workers to be able to provide the mental health care that is needed out there. So I think in part, we all are going to have to play a role in that. And being in the heart of the tech world, I think there's some really cool, interesting things that are coming out in terms of app-based CBT, app-based even hypnosis, where it's kind of interactive. And then kind of my personal favorite is virtual reality, in terms of, there was a virtual reality program that was FDA has stamped or approved, not approved, but FDA designated for chronic pain. And there's a team at Cedars that's working on one specifically for irritable bowel syndrome. So I think leveraging technology to meet some of the demands for our more mild to moderate patients, and then reserving Meredith or Dr. Craven for more, are more severe.
This is from Sangik Chang. Thanks for addressing the cost of care. Awesome study showing that better care is cost effective. I do wonder if they use the hyper expensive new drugs in their care model.
They did not look at drugs in that study. So there's been no studies that have looked at whether or not adding diet or cognitive behavioral therapy allows one to reduce the use of medicine. And so I think that's, if there's any cost-effective folks out there who want to look at that, Meredith is more than happy to participate. I love volunteering people for other work.
But I will say too, in comparing long-term efficacy, so if you're on medications long-term versus 6 sessions of CBT, then there's cost effectiveness there.
Just this dovetails to that previous question. Has optimized pharmacological treatment been compared to multidisciplinary, the multidisciplinary team approach? Standard care is usually suboptimal use of medications.
Well, I mean, we'd have to assume that the standard of care that was provided was by a gastroenterologist who knows what they're doing and has optimized care, as someone who likes to think of herself as someone who knows how to use drugs and can optimize care. There are patients where I alone cannot get patients better. I mean, I've used every tool in the toolbox that I can think of, whether it's exercise, diet, drugs, home, acupuncture, herbs. I can't get people better to where they need to be. And that's why we need someone left.
Congratulations on excellent work and demonstrating the superiority of psychological approaches, including hypnosis, in managing this complex medical problem. Is it not the case that the ability to enhance psychological control over these GI symptoms goes beyond controlling fear and avoidance?
Yes, of course. And I wanted to touch on those two processes because those are two that tend to drive the worst symptoms and the most impairment in terms of impairment of functioning and quality of life. But we do address a wide range of things that can drive symptoms, including, the role of trauma. We know trauma is a big risk factor for digestive disorders, and people tend to hold that in their body. So that can be an important factor to address.
Yeah, one other thing, and Meredith, you could probably address this a little bit more, is the role of acceptance commitment therapy, especially in patients who have kind of a post-viral DGBI, where prior to their viral infection, they were fine, they could eat anything, do anything, then all of a sudden they have an infection, whether it's norovirus or COVID, and all of a sudden they're left wondering, well, I used to be able to eat X. I want to be able to. Why can't I go back to my life beforehand?
Right. And I think as you mentioned, that acceptance piece is really important, of accepting where we are in this present moment and how can you continue to engage in a life that's meaningful and valuable to you.
Great. Is CBT and hypnosis covered by insurance?
Great question. It depends. A lot of insurance does cover it, yes.
How does the opiate crisis affect these GI diagnoses, since constipation is the most common complaint that you mentioned?
So opiates, in terms of functional constipation, that excludes patients who are taking chronic opiates. So it would be diagnosed as opiate-induced constipation or opiate-exacerbated constipation. That's someone who was previously constipated and then is taking opiates, and cause it, which makes it worse. So yes, opiates can worsen constipation, but there are other factors of chronic long-term opiate use in terms of causing sort of what we call glial cell activation. And then essentially what you see is something we call narcotic bowel syndrome, where then they're requiring higher doses of opiates in order to control their abdominal pain. And the treatment is actually to then use a neuromodulator and then wean off.
Someone's wondering if there's any evidence for simultaneous use of multiple neuromodulators in IBS, given concerns for polypharmacy.
So yes, we do use multiple neuromodulators in a stepwise approach in terms of augmentation. Polypharmacy is definitely always a concern. And when I choose neuromodulators, I think about, all the other things that patients are dealing with. So for example, if someone has IBS diarrhea and migraines and insomnia, I'll choose a sedating tricyclic antidepressant to start with, because then the TCA will help with the diarrhea component, will help with the IBS. TCAs are known to help with migraine prevention, and because of the sedating effects, it can help with sleep. So I try to get 2-for-1s or try to treat multiple symptoms as much as possible. And then, taper off. So if someone's on an SSRI for their anxiety, but I need something for pain, I'll switch them over from an SSRI to an SNRI.
Okay, this is a little bit of a longer question stem. Double-blinded studies comparing these cognitive treatments with other non-treatments would be impossible. How can we be sure that these treatments are truly efficacious? As a radiologist, I see many patients with globus symptoms looking for an anatomical obstruction on barium. Few have them, although some do, such as a cricopharyngeal muscle discoordination. I have always assumed that the patients with negative studies have a problem that is invisible to me, like a minor esophageal or pharyngeal injury that might occur while swallowing a pill without water, and I reassure them. They seem to improve over the same time course you describe. Am I practicing cognitive treatment without knowing it?
I mean, the placebo effect is real, or suggestion is real. And there's actually been some interesting research around this of providers, physicians giving a suggestion that patients will improve, and patients are improving. So I think that you're not technically doing cognitive behavioral therapy, but it sounds like the suggestion is having a role or is having benefit. And I think, as Dr. Nguyen mentioned, having a good conversation with your patient around their diagnosis is very important and can contribute to improvement.
Yeah, I mean, and understanding the placebo effect is something that I know there's several groups out there who are interested in looking at, and Irene and I are interested in this also, is because every single trial, in whether it's irritable bowel, GERD, or anything, we're seeing these huge placebo effects. Up to 40% of patients will have a positive placebo effect. And so, if you give someone an active placebo and you're telling them this is a placebo and they get better, I mean, talk about cost on that's free.
Okay, we have one last question. Would you refer a patient for CBT or hypnosis without pharmacological treatment, or is it reserved as a second line?
I mean, I think this is where the partnership with our patients are. I think that it's the cognitive behavioral therapy, hypnosis, it's one of, for us as a gastroenterologist, a toolbox in treating patients. There are patients who are resistant to seeing a psychologist, so I would not push that on patients. And then there are patients who do not want medical therapy and who are very open to hypnosis. And so it really comes down to having that conversation with the patient, having this a two-way communication.
Yeah, I agree, and not giving it as a last resort. So from the beginning of treatment, starting to talk about it as a potential option.
And to kind of dovetail on that, make sure that you don't say to patients, all your tests are normal, everything is fine, you probably have IBS, why don't you go see Dr. Craven? That's not the way to sell her. Okay? And if nothing is working, don't wait until nothing is working and then refer. It's really a combination.
Great. Well, those are all the questions. Thank you again for such a wonderful talk.
Just want to say thank you, Dr. Sonu, for moderating today's session. Thank you to Dr. Ray Kim for also helping support and set this up. And the great, wonderful questions, all those questions, just one of many ways to how important what you're doing is. Dr. Nguyen, I've said this many times over the years, thank you for everything you do. Thank you for supporting all my patients and me always bothering you all the time. When we have your patients on service, you're so supportive. Dr. Craven, so great to have you here. This is really shows how much you guys care about the whole patient, treating everything about the patient. Next week, we have a Dr. Weiser and Tehrani from UCSF is going to be talking about climate change. Dr. Michelle Berry will be helping us moderate that one. Thanks, everybody, for joining us, and have a great rest of the week.